record. Okay, so the first thing that I want to talk about here is basically about this prostate. So one of the prostate guidelines are here, and one of the prostate guidelines are written in urology. So here in the prostate cancer, there is an other PSA screening guidelines is given. This is what it is. So a lot of people confused it. That is basically the general guidelines. This is basically Urology Association guidelines on PSA. So this is different from that one. That is basically generally overall people are going to screen by that thing. But this one is by the Urology Association. So what we are going to follow is definitely that one. But if somebody have the urology features and everything, then we can go for the PSA screening. So people get confused if we need to do PSA screening or not. If somebody has urological associations like having dysuria, not able to control it, all of those features who can present with the prostate cancer, we will do PSA screening. So this one is Urology Association one. So don't confuse this one from that one, okay? Then coming back to abdominal aortic aneurysm, it is written here in this vascular surgery. So here, abdominal aortic aneurysm. So this is written on the sidebar here. Canadian Society of the Vascular Surgery abdominal aortic screening guidelines recommend. So what are we going to do on time screening? When are we going to start? So as I told you in screening, what you need to remember is when did it started, when did it end, like time period, then what are the tests that you need to do and which people are should be applied for this one. Okay, so then in this one, what test we will do? Ultrasound. Then when will it start? 65 to 80, but in men. In women, we will do 65 to 80, but there is conditions applied. You need to know which conditions are specifically for the woman. So in the man, if that particular person is coming after 65, you are going to go for it. In man, there is high risk chances of having abdominal aortic aneurysm, but in women, 65 to 80 with smoking history, cardiovascular disease, first degree relative after the age 65. So these are the conditions that can be applied. Then you are going to do that. So in the first degree relative, either man or either woman, both you have to do. So as you can see, this is 1, 2, and 3. 3 points. Man is this, woman with smoking, with cardiovascular history, then you are going to do. And if men and women both have first degree relative with abdominal aortic aneurysm, then you are going to do in both man and woman. Repeat ultrasound in 10 years. So when are we going to repeat it? As I already told you, we need to know when are we going to repeat it. This one is important as well. So 10 years after initial screening, if aortic diameter is more than 2.5 centimeters. So let's suppose if you did this ultrasound screening and you didn't find anything, do we need to repeat it? No, we don't need to repeat it. But if it has something like aneurysm, which is more than 2.5 centimeter, then we are going to do that like 10 year and so on. So this is the screening of the abdominal aortic aneurysm. Then coming back to here, so which one was that one? Osteoporosis. So the screening of the bone mineral density. When are we going to do the osteoporosis? Sorry. Okay, there. So this is the whole table of the osteoporosis is written very nicely. Where are we going to do what? So let's suppose if the female particularly is coming less than 60, usually we start after like 65, right? So there are particular conditions when you are going to start before 60. What are those conditions? Like less than 50, frailty test, use of the high risk medications, hypogonadism, malabsorption syndrome. So these are all the conditions which can cause osteoporosis. So in the age less than 650, all of these conditions, you need to do osteoporosis screening. So chronic inflammatory conditions, primary hyperparathyroidism, and other conditions strongly associated with the rapid bone loss. Then coming to more than 65, then you are going to do practically all men and women who comes with within the criteria, because vitamin D deficiency is very common in Canada. So that's why in after 65 you do in all men and women. Then coming to 50 to 64, who will be in that part? So starting from 50 to 64, frailty fracture after age 40, prolonged use of glucocorticoids having steroid effect on the bones and mineral deficiency. So everything is linked with that. Otherwise, which other drugs, medication? So which other medications can cause osteoporosis? I want you to write down the answer in the chat box and I will tell you which one are those ones. Okay, so because this is important, so I want you to write it down. Then coming the parental hip fracture, vertebral fracture, osteopenia identified on the radiography, high alcohol intake or current smoking. So don't forget that smoking also causes osteoporosis. Then lower body weight and major body loss and other disorders strongly associated with the osteoporosis. Initial BMD testing and assessment of the fracture risk. Then you have to, so what are we going to do here? Let's suppose this criteria, and this criteria, any of the criteria met. Now we are going to start with the bone mineral density testing. Now coming to that bone mineral density testing initially done, then we are going to do the assessment of the fracture risk, like how much chances of having the fracture in this particular patient. If that low risk is basically 10-year fracture risk, like less than 10%, unlikely to benefit from the pharmacotherapy. What are the pharmacotherapy? Like giving calcium or vitamin D, or even needed with the bisphosphonates. So you don't need to give that medications to that, but calcium and vitamin D is okay. It is given to all of the patients. So bisphosphonate, they are talking about bisphosphonate, particularly pharmacotherapy. Which pharmacotherapy? Bisphosphonate. So giving calcium and vitamin D is okay for everyone, every particular age, not just in the frailty fracture, having frailty fracture or not. It's totally okay. We are going to give calcium and vitamin D, but pharmacotherapy, which one? Bisphosphonate. So if in low risk you're going to give bisphosphonate, it's not going to give any benefit. Then coming to the higher risk, obviously you are going to give bisphosphonate because they are at the higher risk chances of having this problem. Then coming to moderate is basically they have high or low. In middle of that, they are like 10-year chances of 10 to 20%. So now what you are going to do? Either lateral thoracolumbar radiography like T4 or L4, or vertebral fracture assessment. So you can do either of them, not doing both of them. Like you can do radiography, along with it, you have to do vertebral fracture assessment, may aid in decision making by identified vertebral fracture. So what are those assessment factors? These are all factors warranting consideration of the pharmacological therapy. What are those additional, like vertebral fracture? So you have to remember all of them, like wrist fracture in the adults, age more than 65, T-zone, and then lumbar spine less than femoral neck. So you have to remember all of these ones. Rapid bone loss, men using androgen, like having those androgen effect on the bone. Then in women, aromatase inhibitors, tamoxifen and loxafen, all those things. Then using a large amount of glucocorticoids, like for the very long time. Then criteria, and then recurrent falls or associated risk factors, like which is osteoporosis, bones, like having osteomalacia, or like those rheumatic diseases, or everything which is linked. So you are going to do is BMD in 1 to 3 and reassess the risk. So if it is coming in the moderate risk, right? So what are you going to do is further you are going to either do radiograph, or you are going to do a fracture assessment. You are going to fit all of those conditions which is patient presenting with into this criteria. And on the basis of that, you are going to check if the patient needs pharmacotherapy or not. If everything fits in, then you are going to start the pharmacotherapy. If that doesn't fit in, what are you going to do is you are going to repeat the BMD in 1 to 3 years. Usually it's done once in the life. If it's like, comes out normal, you are not going to repeat it. But if that particular patient needs it again, then you are going to do it at 1 to 3 years and reassess the risk. Okay, then on the side, how much calcium is given and everything. Okay, so this is disorders associated strongly with the which one? Primary hyperparathyroidism, like type 1 diabetes, osteogenesis imperfecta, uncontrolled hypothyroidism, hypogonadism, or premature menopause, Cushing, and chronic malnutrition or malabsorption. Then chronic liver disease, COPD, and chronic inflammatory disease, like which inflammatory disease? IBD. Then 10-year risk assessment fracture, CORAC, and has been validated in Canadian population. So doing this FRAX and CORAX is kind of okay. So this one is written, I don't know which chapter, but they said you have to start from the FRAX, then do BMD. So it is totally fine, because FRAX, what is FRAX? FRAX is basically you are doing this assessment testing, and on the basis of that, you are finding if that particular patient needs BMD or not, because BMD is kind of expensive. You are using government funds, and you need to see if that particular patient needs it or not. So on the basis of that, you are going to move on to the next step, which is BMD. So this is basically FRAX is basically asking those questions and fitting the patient in that criteria. And then on the basis of that, you are going to decide if that patient needs BMD or not. Okay. So there is the approach to the clinical assessment, how you are going to see. So as I already told you, you have to see hearing, vision, gait, fall. This is something you cannot miss in the old people. So somebody who's coming after 65, that is basically considered in the geriatric population. So these are the particular things you cannot, and asking about the medication, asking about any substance abuse. So these are the things you have to rule out in history: falls, fractures, hip fracture, gait. or glucocorticoid use, smoking and alcohol, and rheumatoid arthritis. Why I'm asking about vision and hearing? Because vision and hearing could also be one of the cause of the falls, right? So these are also linked with the falls. That's why vision and hearing was also important. So don't forget about those ones. Physical examination, height, you have to check the rib to pelvis distance, like less than 2 centimeters, as this is already written here. This distance and everything, blah, blah, blah. So everything is written here, okay? Then occipital distance more than 5 centimeters, assess frailty by ability to get up from the chair without support. So this is basically a test that is performed. You have to ask a patient to get up from the chair without support and walk for certain steps and return back, so you can see how the gait is, how the refracture is. So this is basically performed in neck, but you still need to know a little bit about it, so you can write if they ask you which kind of physical examination you are going to perform in QE1. So investigations, what are the investigations? You have to rule out all those particular diseases that can cause it. It is very nicely written in endocrinology. If you go there, hypercalcemia and hypocalcemia, our table is written there, how you are going to see CBC, creatinine, calcium, ALP, TSH, and vitamin D. Let's just directly jump to there. So this one is written here, osteoporosis risk factor. If you do it from there, it's more than enough. Everything is written very like in that table. But if somebody wants to go like very deeply, you can go here. This one from endocrinology, osteoporosis, a lot of osteoporosis is written here. Okay. So what are the treatment? Treatment is basically lifestyle modification, starting from non-invasive one. What is non-invasive? Giving calcium and vitamin you can give in the normal population as well. It's not particularly you can start in osteoporosis. So lifestyle along with calcium and vitamin D. What are the lifestyle? Other lifestyle: exercise, smoking cessation, caffeine, osteoporosis. So talking about, if they particularly tell you that the patient is a smoker, they want you to write down in the CDM or in the MCQs that you talk about smoking as well. If they are giving you 2 to 3 lines, or choose at least 5, or choose 2, or choose 3, so you have to talk about smoking. Even in NAC or even in QE1, when they are giving you about smoking and alcohol, you have to talk about it eventually. So this is important. Okay. Avoid osteoporosis inducing medication. As I said, write down the medications which are causing osteoporosis. So we'll talk about those ones. Then bisphosphonate, first line is the prevention of the hip. So that's why we are going to start with the bisphosphonate. You have to prevent from the fall. If the fall risk is low, then you're not going to give bisphosphonate. There's no point of giving it, right? Non-vertebral and vertebral fractures, which one are those ones? Alendronate, risdronate, and then zoledronic acid. Along with that, you have to tell the patient that you have to eat it like, in the morning, first thing, and, all of these things. So know a little bit about how you are going to counsel about the bisphosphonate. Then rank L inhibitors, denosumab, first line for the prevention of the hip. If you cannot give bisphosphonate and patient have an intolerance to bisphosphonate, you can switch on to which one? Rank L, which is basically denosumab. Okay. Then parathyroid hormone, which is basically teriparamide. It can also be used in alternative with it. And then sclerostin. So if you remember bisphosphonate, rank L, that is more than enough. But if still you can remember these ones, like why I said don't forget these ones, because if then let's suppose the option is given and you are not totally blank about that option, if you read any of those options answer in any of the question, you can exclude on the basis of those answers that particular disease. Let's suppose a disease is written and you don't know, okay, this clinical features fit in which criteria. But those answers, this one is not included in this one, this not included in this one, this not included in this one. And then last one, you don't even know. So you can link with that one and easily build up your diagnosis on the base of that. Okay. So coming to the next one, treatment specific to postmenopausal, which is basically you can, in the postmenopausal, what are you going to start with? The SERMs or HRT. HRT can help the prevention of the fall. So it has more risks than benefits combined with the together than vertebral total fractures, risk of the breast cancer, cardiovascular. So it increase these risk ones. Which one? Breast cancer, cardiovascular cancer, and DVT and pulmonary embolism. Okay, now we are going to go back and let's start the important topics first, and then we will do the least important. At least like family medicine, everything is important. So I'm just doing like, I would say more important ones. Okay, let's start with the dyslipidemia, then we move on to the dyslipidemia. Okay, so dyslipidemia, then move on to the hypertension. So dyslipidemia, you need to remember this little bit of criteria. How I remember, I will tell you. So first you need to know, we are going to do is Frankman risk score. You don't need to know how does that calculate or how does it work or something like that. Knowing about Frankman risk score, what is the name of it, which is used for the dyslipidemia is Frankman risk score or cardiovascular life expectancy model. Going very detailed about that thing is not going to help you, and it's not going to be asked a lot about it. Okay, just knowing about the risk score, which risk score is the name, how you are going to use it, that's important. Then cardiovascular life expectancy model, repeat screening every 5 years for the Frankman less than 5%, or every year if more than 5%. Then no pharmacology, and then primary prevention condition and statin indicated conditions. Now you are going to see which patient needs statin, which doesn't need statin, or which is highly needed statin. So no pharmacotherapy if Frankman risk is less than 10%. Now coming to the 10%, you don't need to do it. This is like how it is, right? Now coming to here, where the risk is intermediate, like between 10 to 19, like after 19, you are going to start the statin. This is high risk. Now what comes in the between, like 10 to 19, you need to remember LDL at least. There is HDL written, ApoB written. You can remember them if you are good with numbers. What I remember was LDL. LDL is giving you more than enough information to choose if you need statin or not. It is very nicely written in endocrinology. After this, we will move on to endocrinology, and I will show you how LDL is more than enough to tell you you need statin or not. Okay. Then what other conditions, like having man or woman more than particular age, which one? Man more than 50, woman more than 60. One additional factors like low HDL, impairing fasting glucose, high waist circumference, smoker, hypertension, other modifiers, CRP, coronary artery disease, and family history of premature coronary artery disease. So these are the conditions that could be implied along with it. Okay, then coming to the statin induced one, which one is those ones? If somebody is coming with abdominal aortic aneurysm, either 2.5, either 3, what are you going to start? You have to talk about statin. If you don't write statin and you are writing about, I will screen, repeat, and blah, 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 that isn't going to give you any mark. The thing they want to listen is statin. Most diabetic, including age more than 40, age more than 30 or 25-year duration, microvascular complicated disease, and chronic kidney disease. And LDL, if more than 5, like having familial hyperlipidemia. So before moving on, these are the side of the signs of the hyperlipidemia. So if you are reading these ones, make sure go to the Google and see how does it look like. More than knowing what they are, how does it look like is more important. Like having atheroma, like how does it look like in the outside? Like this one is inside the arterial walls, so it is not going to show up in the picture, right? Like patient is not going to present you that I have something in my arterial wall, so can you see it? No. So all those things like having xanthelisma, this can present in outside underneath the skin. So you need to know how does it look like, okay? Then tendinous, if it deposit in the tendon, so you need to know how does it look like from outside. Eruptive, it does look like from outside, how does it, presentation, painful, papular or nodular. Then lipemia retinalis, how does it look like in the eyes? Retinal blood vessels and extreme hyperlipidemia. Then corneal arcus, how does it look like on the cornea? Except for the arthroma, at least see all of these pictures, how does it look like when you go, and because it's kind of important in derma as well. Then coming to the discuss behavioral modification. So discuss behavioral modification, what are you going to do is part 1 is smoking cessation. This is basically behavioral, right? Before starting statin, what are you going to start to counsel the patient? If they started statin and didn't stop smoking, there's no point of it, right? So you have to start from the behavior, then moving on to the statin. Pharmacotherapy comes after. The first thing is non-pharmacotherapy approach about behavior counseling. As I keep on telling you, the counseling comes first, or the talk about non-invasive procedure, either investigation, either in treatment, those comes first and carry a lot of weight, because they want you to tell patient particularly what he needs to change before starting any treatment. Any treatment will work, but if their behavior or lifestyle modification doesn't change, the medications is not going to help as much. Okay. Then smoking, diet, exercise, like exercise, how much? 150 minutes per walk. Then you are going to start along with it, initiate statin. Then what should be the target is LDL should be less than 2. As I told you, I just remember the LDL, so it is giving you much information. So it was more than 3.5 here. Now our target should be less than 2. If you can remember APO and non-HDL, go for it, but something like. Then LDL more than 50% reduction, then target achieved on the maximal. So you need to see, you have already given statin. Now, is it like working or not? This is basically target achieved or not. If yes, then keep on monitoring and see the health behavior as well. They keep on mentioning health behavior because it is very, very, very important. Then moving on to that, if let's suppose it doesn't work out as much as we want, now what are we going to do is add on therapy. What you can add is ezetimibe, PCK9 or SPCSK9, which is second line, then ezetimibe or PCSK9. So you need to know individually what are their side effects. Individually, when you are going to add to the statin, what happens? So it is written here that if you add, use with the caution when prescribing combined statin and fibrate therapy. What happens is, because it will potentially increase the myalgia, CK elevation, myopathy, and rhabdomyolysis. So that's why it is kind of not used this with the fibrate therapy. Okay. Then moving on to the next one, this one is assessment. What is this assessment? All of that thing that we read here, this is all written here. So what are the assessment? Screen with a full lipid profile like every 1 to 3 years in the A, male and female more than 40. So this is basically written off the what is called screening of the hyperlipidemia. When are you going to do is every 1 to 3 years. When it's going to start in more than 40, which population, male and female both, and what are you going to do is lipid profile. So this is basically a screening whole line. If you can remember this one, this is more than enough to remember for the screening. Who are and all those which one who are menopausal and at any age with additional dyslipidemia risk factors, like having these ones, all of these ones, risk factors for the screening of dyslipidemia. So if anybody fits in this criteria, you are going to do it regardless of the age. Man and woman more than 40, increase incidence in the indigenous and the South Asian. That's why I said, if a male is coming at 25 age, if they ask you to choose one screening, what are you going to do is basically, and that particular person is South Asian. So you have to do is 40, like coming from Pakistan, coming from India, coming from Bangladesh. Those things you have to do is dyslipidemia. Then current cigarette smoking, type 2 diabetes mellitus, arterial hypertension, family history of premature cardiovascular disease, family history of dyslipidemia, erectile dysfunction, CKD, inflammatory disease like lupus, rheumatoid arthritis, psoriatic arthritis, IBD, because in this particular patient, they're using steroids. Steroid causes this problem, okay? HIV infection, COPD, evidence of atherosclerosis, abdominal aortic aneurysm, and dyslipidemia, xanthelisma, cornea arcus. So this dyslipidemia sign stigmata. Then obesity more than 30 and hypertensive disease of the newborn. Non-fasting lipids versus fasting, which one is good one? So non-fasting can be used for the fragment. Okay, sorry. Then LDL cannot be calculated with a triglyceride more than 4.5. Okay. So what are the tests in the lipid profile you choose? So what are those ones? Total cholesterol, LDL-C, HDL-C, triglyceride, calculated HDL-C, glucose, EGFR, basically checking for the kidney as well. Along with the screen for the secondary causes was, what are those secondary causes, like having hypothyroidism, CKD, diabetes mellitus, nephrotic liver disease. So if somebody has this one, along with these disease treatment, what are you going to check for the full lipid profile? So this is basically association of one disease with another. You need to know which disease is associated with the which disease. Then coming to the risk category, those Prangman risk scoring, already you have known about this stuff, okay? So here, what was the thing? To be completed for the male and female, 40 to 45 every 3 to 5 years, the same line that we already read. Then this one. What is it called? Sorry, it skipped my chronological age, I guess so. So you need to know, sorry, cardiovascular age. Cardiovascular age is calculated as the patient's age minus the difference between his or her estimated remaining life expectancy. So it is kind of important because, you know, sometimes they can ask you in MCQs if, like, I'm not saying like it's kind of that, but if they ask you, okay, used to increase adherence to the therapy and reaffirm positive effect of the following therapy, then treatment with the LDL, and if moderate to moderate risk and LDL is less than 3.5 decision threshold, shifted to apolipoprotein, and others are basically total cholesterol, HDL, apolipoprotein. So you need to know, like, increase adherence therapy, when you need to know, and when you are going to start with the following therapy. Then comes to the management. Management is very, very important. So when you are going to start with the statin, and already we read when we are going to start the statin, so everything is over there in that particular chart. So how you are going to start with the smoking cessation, dietary modification, which fats they can take, which meat, which sugar, alcohol. So you need to know everything so you can talk about it. Okay. Then physical activity, how much time he need to start and how much activity, either it's a walk, either it's a vigorous activity, what kind of exercise he needs to do, about of more than 10 minutes to reduce the cardiovascular risk. Then coming to the employee consistent lifestyle modification for at least 3 months after considering the drug therapy. So you are going to check for those things. When are you going to rescreen it, or when you are going to check again is basically 3 months. Then coming to the pharmacotherapy, as we already read, which ones? Statins. So you need to know the risk factors, what it can cause is myopathy. Then if severe side effects, then you are going to switch it to the next one, which one is it? Is it my PCSK9? Then post acute coronary syndrome, cholesterol absorption like ezetimibe in addition to the simvastatin reduce mortality. So if you're going to use it together, it will reduce the chances of mortality. Then coming to here, what are the monitoring tests you are going to do? So the baseline test you need to do, and what tests you are going to perform again. Then it's basically, you are going to check kidney, you are going to check muscles, you are going to check the liver, these three at baseline. Then you are going to repeat it again at 6 weeks later. When are you going to do it? Before starting the statin. Then when are you going to repeat it? After 6 weeks, because you are going to see if it has affected your liver, kidney, or muscles, because it causes fibromyalgia, rhabdomyolysis. So you need to keep on checking it for the signs of transaminitis or myositis and tolerated risk in CK up to 10 times upper limit of the normal, like 2 to 3 times if symptomatic. So this is what it is rated. If CK is showing up, like you check the CK level, and now you see that CK level is more than 10 times of the normal limit. So you need to switch this drug. You need to stop statin, or versus 2 to 3 times, if like not 10 times, but it's not having much symptoms, but having 2 to 3 times, like it was normal limit was 10 and now he's having 20, but along with the symptoms, now you are going to start the statin right away because it's kind of causing a problem. Serum creatinine rise of less than 25%, no routine repeated test for done for ALT and CK. Once it's settled down, you don't need to keep on repeating it again and again. In asymptomatic patient, you don't need to repeat it again. If adequate response is achieved, so you have to do is, when are you going to repeat it again? 6 to 12 months. Then comes the metabolic syndrome, obesity, waist circumference for more than 94 and waist circumference less than 80. In endocrinology, this waist circumference is different in different population. So just go over there and see a little bit about it. At least remember this normal one, okay? Like it's a general one, not normal one. Then coming to the risk factors, triglyceride should be more than 1.7 to make this diagnosis, then HDL plus any of the two. So this is important. Obesity along with two of these ones will make the metabolic syndrome. So if the patient has obesity along with either HDL is low or either BP is high, either fasting glucose, this patient will have metabolic syndrome. Mostly people have metabolic syndrome who has BP, because BP along with fasting glucose, along with obesity, it will make metabolic syndrome. It doesn't need to have HDL or triglyceride. So you need to remember these values. Then isolated hypertriglyceridemia does not increase the cardiovascular risk, and normal HDL, total cholesterol, and elevated HDL. So if having hypertriglyceridemia, they ask about if doctor, if my chances of having cardiovascular risk is high, so you have to tell no. Okay. So don't hesitate to write down answer any. If there is no, it's totally okay. Physical therapies, what are you going to counsel about? Basically, lifestyle modification, smoke loss, weight loss, smoking, exercise, and effective blood glucose. And then severe hypertriglyceridemia and drug therapies, nicotinic and fibrates. So we are going to stop here, and then we are going to start for tomorrow from hyper. First, we will do exercise a little bit. It's not that. And then we will do hypertension. Okay.